From a clinical standpoint, ADHD is not a deficit of attention, and it is not a failure of willpower. It is a disorder of regulation centered on weak top-down control by the prefrontal cortex. This region holds your goals online using fragile self-sustaining loops of neurons, the brain's mental sketchpad. In ADHD, that prefrontal control system is underengaged, so attention, impulses, and emotion are all harder to steer. What tunes that prefrontal network are two catecholamines, norepinephrine and dopamine. Their effect follows an inverted U, too little signal or too much, and the cortex performs poorly. There is a narrow optimum in the middle. Norepinephrine, acting on alpha-2A receptors, strengthens the network's connections. Dopamine, acting on D1 receptors, sharpens the signal by turning down the surrounding noise. So ADHD is better understood as catecholamine dysregulation than as simply low dopamine. Zoom into a single synapse, and the pharmacology comes into focus. Normally, transporter proteins called DAT and NET pull dopamine and norepinephrine back out of the gap, ending the signal. Methylphenidate simply blocks those transporters, so the transmitter lingers. It is a pure reuptake inhibitor. Amphetamine goes further. It blocks them, reverses their direction, and empties the storage vesicles, actively pushing transmitter out. Both raise catecholamines in the synapse, but amphetamine is a releaser, not just a blocker. Not every treatment is a stimulant. Atomoxetine selectively blocks the norepinephrine transporter, which in the prefrontal cortex lifts both norepinephrine and dopamine at once. Because it spares the reward circuitry deeper down, it carries little abuse potential, but it can take 4 to 6 weeks to work. Guanfacine and clonidine skip the transporters entirely, directly stimulating alpha-2A receptors to brace the network from the receptor side. Different doors into the same prefrontal room. Does it work? The evidence here is among the strongest in all of psychiatry. A network meta-analysis of 133 controlled trials, covering roughly 18,000 people, found every active drug beat placebo. Stimulant effect sizes were large, approaching 1 full standard deviation for amphetamines in children. In practice, methylphenidate is first line for children and amphetamines for adults, and about 70% of patients respond to a given stimulant. Formulation matters too. Extended-release versions trade a slower onset for steady, all-day coverage. Clinically, the diagnosis still rests on a pattern of behavior, not a brain scan. The DSM-5-TR describes 3 presentations: predominantly inattentive, predominantly hyperactive impulsive, and combined. Several symptoms must appear before age 12, show up in more than one setting, and genuinely impair daily life. ADHD is also highly heritable. Twin studies place it around 75%, and it affects roughly 5% of children and 2 to 3% of adults. The through line is simple: a dysregulated prefrontal signal and treatments that retune it. This is education, not medical advice, and any diagnosis or treatment belongs with a qualified clinician.